Good evening, friends. A warm welcome on behalf of MIDAS Institute of Gastroenterology and MIDAS Medical Foundation. Um, this is not a clinical meeting, but an extra meeting where we are um, discussing the role of endoscopy in the treatment of oncology. Uh, we have encountered with so many interesting oncology cases. We thought that we share our experience with the oncology group in the city. So we are making this as part one, and because we are unable to join the rest of the cases, so this is role of endoscopy in management of oncology cases. Probably the second theme would be more of interesting tumors which we have encountered in our practice. So, may I request for today's meeting the chairpersons, Dr. Anand Pathak, Dr. Ajay Mehta, Dr. Amol Dongre, and Dr. Abhinav Deshpande. We have our online chairpersons, Dr. Ajay Jain, who is a consultant gastroenterologist from Chaitram Hospital, Indore, and Dr. Sridhar Sundaram. He is a consultant gastroenterologist, intervention endoscopist from Tata Memorial Hospital, Mumbai. We have interesting cases. So, without wasting time, I request all the chairs to please occupy the dais and start with the proceedings. Thank you.
Good evening, everyone. Let me congratulate Dr. Tiwar and his team for having this interesting topic of endoscopies and in oncology part 1. Let's first start with new endoscopic therapy for biliary cancer. The speaker would be Dr. Bhushan Haure.
Afternoon. Good evening, everyone. Today, I'm going to discuss regarding new management of. So, this is a 65-year-old male. We presented with a painful obstructive jaundice with a weight loss since last 1 month. Outside investigation found to have an normal CBC deranged LFT in the form of obstructive jaundice with the total bilirubin rising to 19 in the span of 1 month. With viral markers were negative, he was having a good serum albumin, and the CA 19.9 was significantly elevated to more than 5,000. So with this background of an old male, with we are really was dealing with something like a malignant form of biliary obstruction. So the first investigation what the patient brought us was a CT scan. We showed a moderate intrahepatic biliary radicals with collapse gallbladder, and it appears to be a sometime a complex hilar block with suspected liver SOL in segment 5 segment 5. So for about uh, something intrahepatic cholangiocarcinoma type of picture. For delineation of and further evaluation for any intrahepatic cholangiocarcinoma with a complex hilar block, the investigation that we also recommend for determining the type of stricture is an MRCP. What we did which discussed like we can see a completely separated right and left hepatic duct with right anterior and right posterior joining together, and the mass is more infiltrating into the duct. was what we saw on MRCP. So with this picture of an elderly male with a good, we can have a good performance status and with an MRCP and CT suggestive of, and we are dealing with an malignant hilar biliary obstruction. We involved upon hepatobiliary surgeon regarding the operability status, and the only one thing that found in our that there was a liver as well in segment 5, which we tried to do an UHG guided FNSC, and that UHG guided FNSC sometime turned out to not like in a very classical type of picture, but given a differential, it can be a normal because the needle might hit a normal liver tissue, and it may be because the lesion can be neuroendocrine tumor. Dr. R. Ravi sir is yeah sir. And subsequently, to further enhance that liver SOL, we did a liver biopsy from that SOL. From the SOL, what we did, might be Dr. R. Ravi sir will comment on it. Sir, I think we don't bought our liver biopsy. Is it, sir? Okay. It's any comment on, sir, like what can be a liver, what you found on your liver this SOL biopsy, what we found. Yes, sir.
Actually, what we saw was very richly cellular smears where we did not see any malignant cell.
Yeah.
But because there were biliary radicals which were dilated, probably the exfoliation of the bile duct cells, they almost looked like a neuroendocrine tumor. I was in the heart of my heart very sure that this was a parenchymal lesion because the needle had probably not hit the lesion. But however, a neuroendocrine tumor was on the cards because on cytology there is really limitation. And when we did the histology was also not very diagnostic. We saw some atypical ducts. We thought that maybe this is a cholangiocarcinoma. There was changes of chronic hepatitis, but we could not dogmatically tell that this is malignant. There were
Right.
some atypical
Right.
ducts, that's all.
Right. So with this dilemma, because that liver SOL going to change our line of biliary drainage, because yes, the patient was having a very high jaundice and there was a liver SOL. So we brought our hepatopancreatobiliary surgeon into the picture. Okay, what can be, how we can approach this patient? And sir says, hope Dr. Ravi Mohanka sir is on the online. Is it Dr. Ravi Mohanka sir is online? Yeah. Because he said he will join us for a. So Ravi Mohanka sir said at that moment, okay, this is an inoperable case because there is a liver as well in this, and you can go ahead with with an biliary drainage, depending on so we. He said he said he was partly in a confusion that liver as well might be change this line of management, but he said okay, it is an operable case at that moment. It may not. Is it, sir? Mohanka sir is there. So whatever with a good surgical candidate, which is sounds to be an operable patient, this patient have very high jaundice. This patient was definitely requiring a biliary drainage, and we found that okay. Sir. Yeah. Yes, sir. Let me have some opinion what he was thinking at that moment of that patient when we saw the CT scan and all the images and biopsy.
Yeah, so after looking at the CT scan,
Right,
it looked very operable. The tumor was in the main bile duct at almost the same level as the cystic duct. So there was a good amount of bile duct above that, and there was a good amount of bile duct below that also. So it was suprapancreatic. Also, there was a good space between the tumor and the pancreas and the sphincter, and we thought that we could get away with the extrahepatic resection, and the artery, although the right artery was going very close to the tumor, but it appeared free on the CT scan, and the portal vein both sides were obviously free, so it was an operable lesion.
Yeah. Thank you, sir. So with that, but the patient was really requiring an biliary drainage. So we decided that okay, why not given a best option for this patient for endoscopic biliary drainage? And we in our institution we mostly go with an endoscopic biliary drainage. We decided that we should go by ERCP and metal stenting. But we are also recently bought a new technology called as endobiliary radiofrequency ablation device. And it is very emerging modality that will supplement the conventional management in the patient of malignant biliary obstruction. As you can see, it comes with one energy device, as you can see on the right hand side, with a radio frequency catheter, RFA catheter, which contains an electrodes at 8 junction, which will go inside that biliary stricture and cause tumor ablation by generating a thermal energy. At the same time, that thermal energy is so much so that it will burn the vessels and also open up the tract. So it causes a central necrosis of the tumor tissue, and at the same time it will increase the stent patency also. And I will going to show in the slide that how it also has found to be a survival benefit. So as usual, it is a very simple device. We went with a standard technique. We cannulate the CBD. We entered the wire into right hepatic duct and left hepatic duct. We obtained the breast sampling because always the tissue diagnosis was always we want for the tissue diagnosis. And for confirmation of type of stricture, we obtained a contrast for delineating the stricture, and then we passed this this RFA catheter to the papilla up to the level of stricture, as you can see on the fluoroscopy. And we subsequently, it is a little bit discuss about this device. It is a radio frequency catheter that passed through that the CBD at the level of a stricture. We can confirm on fluoroscopy. It delivers a fixed thermal energy which is going by that as operated. It is mostly at 10 watts and has to be kept for 2 minutes at the particular junction. We ideally, this length of stricture is documented by cholangiogram, as we see ideally in Hilar in Hilar stricture management. We mostly go by air cholangiogram, but since we need to do what is the length of the stricture, we have to inject a contrast so that we for delineating a stricture. So length of contrast was measuring around 2 to 2.5 centimeter. So it is an electrode at the 3 electrode which is spacing at 8 So at the maximum we can have a almost 1.5 centimeter stricture which can be burnt out by this electrode. So we had to really adjust according to fluoroscopic image. We had to keep at 2 position, and it is a fixed kept for 2 minutes. The 10 watt with 10 watt power which is delivered and produces thermal energy and causing a tumor necrosis. So this is how a little bit technical detaility of this instrument. It is a very simple device, just like any catheter. So subsequently, from right hepatic duct, we also burnt a tissue on the left hepatic duct, that stricture. And later on, just like a normal, then we start putting our stent on the right hepatic duct, and also then the subsequent on the left hepatic duct. Yeah. So more about a nice way of doing this thing. So post procedure, the patient has a mild abdominal pain. During a ward course of around day 4 or day 5, the patient bilirubin was reduced from 19 to 7. And during this ward course, the patient has a mild distension, right hypochondria, mild cholecystitis, which was really managed conservatively, and patient was subsequently discharged with a plan from a surgeon that patient may require an surgery in the form of extended left hepatectomy. This was a plan by giving a left. He given a plan to a patient that we embolize the left portal vein and subsequently causing an hypertrophy, and subsequently the patient may be inoperable for that particular stage. So patient also did a PET scan. For that moment, patient also did a PET scan. And PET scan suggests to us same that some liver uptake in the liver in segment 5 is suggests to you more about an metastatic lesion. I think Dr. Mohanka sir, can you really comment after PET CT also you want to operate such this patient? Sir, you are not audible, sir.
Sorry. So the tumor was, even on the PET scan, there was no extrahepatic disease.
No, sir.
The disease was all limited to the hilum only.
Yeah.
And there was no contraindication to go ahead with the resection. It looked like a very operable tumor actually.
Right. So this is how we manage this patient. And currently, just today only, he came there for our OPD, and we are currently admitted, and really we are very forwarding this patient for surgery. So as you all know that optimal stent strategy for malignant biliary obstruction, depending upon the type of stricture for malignant Hilar, either we put a single stent for a type 1 stricture, or more than 2 stent for a type 2, or more than for type 2 or more stricture. But problem with this, what is uncovered stent is that they causes a tumor ingrowth in the tune of frequency of around 35 to 40%, and there is no added survival benefit. As you all know, this is only a palliation form what we are providing for the patient. So what this endobiliary and radio frequency ablation, this is a very nice review article done by Saurabh sir, and will help into the insight about exactly how this endobiliary RFA has come up from in a gastrointestinal system. This is how the cholangioscopic image look before and after radiofrequency ablation. I can see that radiofrequency ablation causes a very nice circumferential necrosis of a tissue, of the malignant tissue. At the same time, it causes an ablation of the microvessel, so that in the trials we are showing it causes a survival benefit also. Not only it has increased the stent patency, it has also increased the survival benefit of the patient, that I am going to explain, showing in Kamal's slide. So this was a very nice multicentric study of an endobiliary frequency ablation which was combined with a bilateral metal stenting, and they are found that recurrent biliary obstruction was seen in 230 days after putting this radiofrequency ablation, with the minor side effects of ranging around 13.2, and the most common adverse event what they document was an acute cholecystitis, as we are found in this patient. And they also found that what is the one thing that will change that biliary obstruction, that patency rate, is a length of stricture. If the length of stricture is shorter, this RFA may not work in that way, because electrodes are spaced at around 8 mm junction from 3. So if the length of stricture is around 2 to 2.5 centimeter, then this radiofrequency ablation really is causing and increasing the stent patency time for such patients. Then this meta-analysis came. Meta-analysis said it not only increased the stent patency, but it subsequently also increasing the survival for this patient. So why not? Yes, definitely. Why not to give an RFA where the survival benefit is also has been obtained at the same moment? So these are the various outcomes of studies comparing the results of RFA and stenting with or without stenting, and all the studies are demonstrating some amount of definitely an overall survival benefit when we do an RFA with metal stenting of this patient. Another indication of this radiofrequency endobiliary RFA is that tumor ingrowth. So it's not like always that we should do before only. It is also a very repeatable procedure. We can do oftenly this RFA, and for tumor ingrowth, the patient come after tumor ingrowth. This is another one example coming in your case that we have tumor ingrowth. We have completely obstructed a stent. We completely ablated tissue which was embedded, and even the stent was removed after this radiofrequency ablation technique. So after this extension from this radiofrequency of endobiliary, the pancreatic RFA is also is coming very strongly in gastroenterology system. It is like, especially currently, the current indication for radiofrequency ablation is for neuroendocrine tumors and pancreatic cystic neoplasm. Dr. Mukhewar sir is going to talk on this little bit about the USRA device. This is a small review of literature about this pancreatic RFA regarding the efficacy, safety of this thing. It has been found that the overall effectiveness of US RFA was around 96% in patient of pancreatic non-functional neuroendocrine tumor, and the limitation of this study was that it should be approximately less than 2.5 centimeter. These are various studies of US RFA in pancreatic cancer. As you can see, the efficacies, though the case samples are like couple of patients, 7 patients, 8 patients, is reaching to up to 100% efficacy at 1 year at least. So this is now another we are extending not only from pancreatic neuroendocrine tumor, pancreatic adenocarcinoma palliation is also a thing that are coming into a way which Dr. Mukhewar is going to speak in his presentation. So in take-home message is RFA is a very useful technology in management of various GI condition. Endobiliary RFA has demonstrated improved stent patency and also has increased survival as well. RFA is also effective now coming into pancreatic neuroendocrine tumor, especially less than 2 centimeter in size. And role of RFA in management of unresectable pancreatic cancer remains to be defined. But yes, it is coming that if it have complementary with a chemotherapy, it may have some like a chemo cytoreductive type of work can be done by this radiofrequency ablation. Thank you.
Nice presentation, Bhushan.
Thank you, sir.
Just 2 questions.
Yes.
What was the cytology?
Yes, sir. The breast cytology was negative, sir.
So we do not know whether we're dealing with a malignancy.
Yeah, sorry. Yeah, sorry.
Second thing, presumably if this is a cholangiocarcinoma and there is a surgical plan,
Yes, sir.
what you are doing is just relieving the biliary obstruction as a bridge to the definitive therapy.
That's it.
For that purpose, is this technique superior over other conventional techniques?
Definitely, sir. If you're saying that if you're the patient, the only problem what your question is that, okay, if you're putting a metal stent and the surgeons finding very difficult to remove that metal stent, that is the one problem for this for that putting this metal stent. Otherwise, the patient having 20-22 bilirubin where surgical plan is also on not in a very strongly coming up, doing this radiofrequency ablation bilateral metal stenting is definitely is going to be a very at that moment of time where I was doing this procedure where surgery was not very strong. This was the best method of palliation what I did for this patient.
Yeah, so one quick update. So this patient eventually was not found to be operable when we did,
Yeah.
So that is the problem. So he was not, the vessels were involved actually on next.
Did you do an US?
Yes, sir. We also did a US for that lymph node. Even Saurabh sir was doing there some small, a small periportal lymph node that also biopsy also negative. So we tried best to get a tissue sampling. We did a brush, we did a US, we did a USG guided FNA, we did a liver even biopsy sampling for acquiring the tissue, but the tissue was coming really negative for this patient.
Bhushan?
Yes, sir. Yes, sir. Sridhar sir.
Hi.
Hello,
Hi.
sir.
So interesting case, I must say. Only thing, I mean, there is increasing data coming in this area now. And I think some of the data that you quoted, so there are two recent randomized controlled trials. One that is already published in GI endoscopy, which was a negative trial,
Yeah.
89 patients, which showed that there was no impact on patency or survival. Second, again, this year at DDW, another RCT was presented, which showed again no impact of RFA, endobiliary RFA, on patency or survival. Now, unfortunately, why this is something that we really need to understand, largely because I think survival in general in biliary tumors is dismal. I think our paper is currently in press, and maybe data on hilar blocks in India is something that I think we're publishing now in the Indian Journal, and our median survival was somewhere around 150 days. So I mean, despite giving them the best palliation with two metal stents like you did in this case, the overall survival in this particular cohort is likely to be dismal. And given the data that is coming up, I think I would still be cautious in using endobiliary RFA as of now. Maybe there is requirement for more data to come in. Like you already quoted, the number of studies is reasonably small, and the recent two RCTs have actually kind of put a hold on the usage that was reasonably widespread. Actually, there is data from 2020 which actually showed that instead of hilar blocks, it is actually better for patency in blocks that were communicating, not in hilar blocks. So again, there is a lot of discrepancy in this area, and maybe, like you said, this is an evolving discipline. Maybe your data will be something that will add, value to it. Maybe over a period of time, maybe you can build your experience and maybe publish it, and that may actually add some value to the amount of literature in this particular area.
Yes,
Can I say something? Yeah, actually, this is a common practice that we manage the patients with hilar blocks. And majority of the times, when they come to the endoscopist, they are being not offered the advantage of surgery. Many a times, we see that this is a type 2 hilar block involving the right and left hepatic duct. So they are not offered surgery and palliated. But having sent the CT scans to hepatobiliary surgeons, we realized that some of them are definitely operable. When they are taken for surgery, I think, Ravi, if you correct me, half of them would turn out to be inoperable. So that is also, even if...
About one third will
Huh?
be inoperable.
Yeah, about 1/3 turn out to be inoperable. Stenting them with the plastic stent leads to complications like cholangitis, especially in an Indian setup, where the accessories are used repeatedly, as a result of which the patients, they deteriorate faster. I think weighing between the putting two plastic stents and operating the patient versus technical difficulties of operating on a metal stent, I would prefer to put the patient's metal stents bilateral and ask the surgeon to operate. Overall scenario is like this. As far as my knowledge goes, the paper by AIG by Mohan Ramchandani on the RF ablation in cholangiocarcinoma, I think that survival was nearly doubled. So I think whatever survival was 120 and 240 days. So I am not aware of the recent trials. Probably Sridhar may be more aware of these trials. But RF ablation definitely reduces the blockade of the stent, thereby re-interventions and improves survival. But probably we would also go into the details and we would like to know, because you are working at a center where there is the last comment would be on establishing a cytological and histological diagnosis. In this patient, we did breast cytology, which is around 40 to 50%. Then we did EUS, and with the EUS, we had a bile duct, biopsy from the bile duct as well as liver lesion. Unfortunately, that is negative. Most of the times, when you have 2 or 3 biopsies, but considering a hilar block in an elderly patient with raised CA125, I think we are more or less certain that it is malignant and nothing else. And looking at the performance status of the patient, which is quite good, we feel that he should be given a chance. I don't know. I think the recent CT has also shown that it is operable. The PET was the recent. So he is still operable unless you have reviewed it and come to know that it is inoperable.
No, sir. The thing was that the remnant volume was very small in this case, and therefore, if we have to do a resection on him, then we have to do the portal vein embolization and all that. And with a bilirubin of 20, it was not possible to subject him to PVE. So now that his bilirubin is down, now that plan can be put into motion.
Now the bilirubin is 2.4.
Yeah. So now it should be possible.
Can I ask a question? One problem with hilar, Ravi, I'm Prashant Bhandarkar.
Yes, sir. Yes.
So one problem with putting metal stents in hilar block is we do obtain breast cytology, and because you're dealing at hilum, you preemptively put metal stents. And then the breast cytology becomes negative because cytology is not 100% sensitive. So we don't know whether it is false negative or true negative. And then we are stuck. Nothing can be done for this patient. So 3 months down the line, patient is doing reasonably well, biopsy is negative, but the cancer diagnosis is yet unconfirmed. And to begin with, the bilirubin was 30 plus. So you won't really think of autoimmune cholangiopathy and all that stuff. So how to get over this dilemma?
So we can't. Unfortunately, we don't have a solution for this. But because the incidence of autoimmune or retroperitoneal fibrosis related and other etiologies related strictures is so low, for all practical purposes, we assume that anything that appears like malignancy on imaging is a malignancy and treat it like that. That's also.
Yeah, I think.
Ravi, can I add a little bit on this? So all these hilar stricture, way back when we started in 1992, taking the brush cytology with Howell needles and all that, the yield was only about 40%. With the introduction of this cholangioscopes and then endoscopic ultrasound, the yield has gone to maybe about 75 to 80%. But yet there is a section of about 20% where you still have doubts about the diagnosis. So one of the practical approach maybe, because nowadays most of the centers have the pathologist available within the hospital. And if you have taken a brush or you have taken an USFNA, and if the USFNA and the brush wait for 10-15 minutes and they say material adequate but no atypical cells seen, my advice at that point of time would be that put a biliary, instead of metal stent, put a plastic biliary stent, wait for a while, let the bilirubin come down, and maybe in another 2 to 3 weeks change and take out those stents, send the bile for the cytology, send those removed stent for cytology, and look at the cancer markers, whether they are still on the increasing side. and maybe a second attempt to re-establish the diagnosis before putting the metal stent. If second time also negative, then rather than putting a metal stent, I'll definitely ask my surgical colleague, you take it up, open it, do a frozen section, and maybe you are rewarded and do some definitive procedure, or you do a bypass and come back. These are the things which we need to consider in those 20% patients where your diagnosis is in doubt.
So I must concur with Ajay sir on this. I mean, it's actually the more pragmatic approach, I guess. The only thing what we have started doing is because to increase yield, we started having a rapid on-site cytopathologist with us, even for our breast cytologies. So if you're doing a breast cytology, even for our hilar stricture, sometimes I mean, of course, there are logistic issues. Not every center may have I mean, it's the luxury of calling a cytopathologist. I must say it's a luxury of calling a cytopathologist, on site. But yeah, I mean, fortunately for us, we do have that, and it definitely does increase it. It at least tells you if your slides are good enough to make a diagnosis, and if you want to repeat a brush again in the same setting or not before you put a stent.
So I think the discussion is pretty interesting, and because of paucity of time, maybe in case if we can move to the next case, which would be endoscopic management complications due to pancreatic cancer by Dr. Shrikant Mukhewar, sir. Thank you so much all present online.
Most of the times when the pancreatic malignancies are diagnosed, they are inoperable. So I'll just tell you a story of a 72-year-old male who came to us in month of October. He had problem of diabetes, hypertension, hypothyroidism, presented with loss of appetite and jaundice, which was obstructive. Bilirubin was not much, but his ALK phos was 3 times elevated. CA19 by 9 was more than 500. This was the MRCP which was done outside, which suggested a block at the lower end of the bile duct and hypo and isodense lesion in the CBD. So this was done outside where they diagnose as dilated CBD stricture, cholangiocarcinoma. Again, the same story that the brush was negative, plastic stenting was undertaken. So when came to us within 15 days of stenting, he had fever, which has started with weight loss of 6 kg. And because the cytology was not positive, the relatives had a doubt what is the basic diagnosis. So we done the CT scan, which has again showed a dilated bile duct, distended gallbladder, and you can see the arrow that there was a mass in the head of the pancreas, which was causing obstruction. So we suggested that the patient should undergo ERCP because he had cholangitis. So patient refused. We also got the EUS, in fact, for this patient. It's a short video of a US which has shown that there was a mass in the head of the pancreas. This is, I think, distended gallbladder. And you can see a mass which was FNA'd. Biopsy showed clear-cut adenocarcinoma. The question was whether it is arising from bile duct or pancreas. The CT and the US both were suggestive of operative disease. Patient was in the age group of 70 and 75. So, operative decision has to be dependent on the patient's relation and the performance status. Majority of the times in our setup, when we say that you are above 70, no surgery. So that's a dictum. So they followed the same principle that we don't want to operate. This was the biopsy. Oh, sorry. Sorry. I went back. After 1 week, came after 1 week with cholangitis because we had advised TRCP. Counts were 34,000 and the bilirubin had increased, which was had come down. Alkaline phosphatase was increased. The plastic stent was removed. Can see that the metal stent was put because the patient said that we don't want to operate. The metal stent was put, and you can see the first mixed bile which has come like a river. It had flowed down, and the pus and the blood culture revealed Klebsiella. Received injection meropenem for 1 week. Patient lost to follow-up. Puzzled about surgery. Had a PET scan in the month of December. We showed a hypermetabolic hypodense lesion involving the segment 8 of liver. It was difficult to differentiate whether it was a cholangitic abscess or a malignancy. And there were small submural nodules were seen in the right lobe of the lung, probably had an advanced disease. Not opted for any treatment. Came again in the March with intractable pain, loss of appetite, weight loss, which was not responding to patch as well as tramadol. And I'll request Saurabh to tell about the celiac plexus neurolysis which was done.
So celiac plexus block was pretty standard technique here. We so what we essentially do in these patients is that across the gastric or the esophageal wall, you find the origin of the celiac artery, and the needle is advanced at the base of the origin of celiac artery, and injection of a mixture of alcohol with steroid is performed, and this provides pain relief to the patients. It's suppose a little safer than IR guided, if I may, because we are actually directly visualizing the presence of the needle in the tissue and not in any blood vessel. And therefore, I think it allows us to ensure that the drug is delivered on site. Now, I can too many things in celiac blocks, but I will not go into the depth. But mostly, most patients get a reduction of say moderate degree with celiac block. And patient, I think I'll just continue for a few slides here and then I'll let Sir take over. So the patient's pain did subside. However, 3 weeks later, he started developing vomiting and had large vomitus, which was non-bilious with stale food. And an upper GI endoscopy was performed, and you can see there's a severe gastritis. And you see there's several shallow ulcers. This was due to stasis of food in the stomach. So this patient ultimately, we have two options for such patients with gastric outlet obstruction. Either you can consider a duodenal SEMS, metal stent, and in this particular case, and the other option is gastrojejunostomy with the help of EUS. And in this particular case, we decided to proceed with gastrojejunostomy. And here is the is that we put a tube across into the small bowel and distend the jejunum with normal saline. And here we are advancing this special stent. In case in the prior meetings we showed similar cases for benign stricture, and here we are showing for a malignant case. Across the gastric wall, the cautery enhanced metal stent is being deployed, and the flanges are deployed, as you can see, with free flow of the bluish color fluid that we have injected. This has a certain advantage overall in terms of the stent patency and patient acceptability. So this was done, and then the patient started on orals on day 1, and eventually semi-solid diet, and then was discharged eventually. Yeah. So.
Thank you, Saurabh. So presently the patient is on palliative chemotherapy at Mumbai. It's not Pune, it's Mumbai. Pain reduced by 70%. In this particular patient, what was the role of US in establishing diagnosis by FNA, FNB, celiac ganglion neurolysis, and gastrojejunostomy? And we plan to, because he's coming from a very good family and the relation wants that whatever you can do. So we just spoke to him that we'll get his EUS guided RF ablation, which is a new kid on the block. Sorry. So RF ablation, as Bhushan has already said, that it causes a coagulative necrosis. And another advantage that tumor antigens are immunomodulatory and they are released into circulation and the antibodies are formed. So that's also an advantage which I was not aware. It's already used with Barrett's dysplasia and bile duct, but in pancreatic lesion it is new. This is about pancreatic. I think this you all know. Unfortunately, to 80 to 85% are inoperable. And what is the role of US RFA? Downsizing the tumor to make it resectable. Sometimes ablation of an unresectable tumor and palliation. And there are 2 trials which has shown the adverse effects are seen in around 5 to 10% of patients, like pancreatitis, bowel wall injury, peritonitis, injury, adhesions. And these are few of the treatment trials of US RFA. Obviously, there is no large trial to establish a benefit. These are mainly in the form of case reports. And that has shown that there is a decrease in the size of the tumor with increased survival, which has been established in 2 trials. Another thing which can be done is called decoduodenostomy in these patients. Through EUS, you can puncture the bile ducts. So there are couple of trials on the primary use of EUS CDS for the as a first treatment. EUS CDS is superior in terms of stent patency and safety than ERCP. At the end of 180 days, 6 months, 85% of the EUS CDS were patent as compared to 50%. So there is less stent blockade, less interventions, and better results. So EUS CDS may replace ERCP as the first line of treatment. Thank you.
So that was excellent presentation, sir. So, sir, this is essentially now, I mean, it is more of a palliation.
Yeah.
As a glorified palliation, we can say.
Yeah.
But this patient seems to be operable upfront. Had the relatives been counseled, I mean, had be ready for the surgical part?
Initially, in the month of October, he was certainly operable. Yeah. The CT scan, the EUS, all has shown that it was an operable tumor. And in fact, his performance status was also good. But same story that Whipple's is supposed to be a very major surgery with risk to the life. If you tell them that 5% chance that you have a risk to the life, probably anybody can think either way.
So normally downsizing of the tumor is what you mentioned in the literature.
Yeah.
Downsizing of pancreatic tumor. So,
Yeah.
I mean, the studies are really very small, but is it like downsizing in a locally advanced beat, make it operable in that sense?
In fact, I'll tell you the concept of this pancreatic surgery, which has been flown, which has come from the US, especially from Milwaukee. They are, even if the tumor is operable, they upfront give a new adjuvant therapy to these tumors because they're saying that when the patient comes, he is in a healthy situation. So giving him treatment, he operates, gets treatment in a better shape. And in this neoadjuvant time, by buying for 2 or 3 months, if there are small seedlings which are there in liver, other sites, 20% of these patients, they turn out to be inoperable if you operate in front. So I think this concept is getting more popularized, and so borderline resectable or upfront resectable also for certain malignancies like pancreas, which has high propensity to metastasize. There is a concept that upfront chemotherapy when the patient is healthy, followed by surgery at a later date. But since you are all bosses of oncology, I should not be.
So essentially what we need to assess is the biology of the tumor, how
Yeah.
it is going to behave before undergoing such a radical surgery.
Yeah.
What is the concept?
Dr. Pathak, your concept, I don't know.
What you're saying is absolutely correct, sir. A lot of patients who look resectable, if you have a chance to observe them next 3 months, they would show metastasis. So increasingly, the definition of borderline resectability is including upfront resectable as well as some locally unresectable, where the surgeon is confident that if the tumor shrinks a little away from the artery or vein, it can come within the surgical limits.
Yeah.
I have one basic question to ask to Saurabh. And Ravi sir also has seen a lot of pancreatic biopsies. Pancreatic cancer is known to have a very fibrous stroma. And that is one of the reasons why therapies fail. In fact, neurotherapies are also looking at targeting the stroma in addition to targeting the pancreatic cancer. So when you employ these local techniques like RF ablation or cryoablation, do you see more patients coming back with complications like pancreatitis, cholangitis, some abscess inflammation, strictures? Already some of these patients do have chronic pancreatitis.
See, basically, the RF ablation for pancreatic cancer is a very new kid in the block. In fact, I would say that it was started for tumors like insulinoma. They are small tumors, and RF ablation done, the tumor responds. Then it had come for neuroendocrine, and then it had come for mucinous cystic neoplasms, which has more potential to get malignant. As far as pancreatic malignancy, there are case reports, but whatever have shown, some two series has shown survival benefit. The others two have not shown survival benefit, and that too in conjunction with chemotherapy. So, and there are about 4 to 5 settings required. The complication rate is only 5 to 10%, like pancreatitis, bowel ischemia, and injury and perforation, and so. Saurabh probably would answer his.
Sorry, what?
Pancreatic RF ablation.
Yeah, I think it's a very new thing, and I think it's primarily meant for neuroendocrine tumors of the pancreas, which are smaller than 1.5 centimeters, because the RF catheter has only so much diameter. So that's really the only use that has been sort of established in some ways. As far as cancer is concerned, there have been issues, there have been complications, but the newer technology with the newer RFA probes have been better, number one. And number two, there's one recent study which has shown some benefit, of course, this is early data, for inoperable cancers when patients did not get surgery. So perhaps something you can consider: an 80-year-old who's not getting the Whipples, has a 1.5 centimeter lesion. You can try it out. Maybe it will prolong survival. But you don't want to do it for a 6 centimeter tumor, which is encasing big vessels, because that's not going to be the one which you're going to provide any benefit. So it's a small lesion, a high risk for surgery or inoperable due to some vessel would be reasonable to consider as an alternate option. That's my take on it. Yeah.
That is the question what you asked. That's why the RFA is taking longer time to reach into pancreatic area. In the animal models, they are sound. So that's why the newer machine by StarMade from Taiwan, this all injury is temperature dependent. So if a temperature is controlled, definitely all this cause of pancreatitis can definitely go. That's why it has been given FDA approval. That's why it has given an FDA approval to apply it in humans. So initially, if you're having a proper 10 watt for at least 2 minutes, they are not caused any sort of thermal injury to the pancreas in the form of pancreatitis or leak or whatever we can imagine in that area in the vicinity it can cause it. So it is exactly the temperature dependent and also duration dependent. So if it all being controlled by that all machine, that's why it is not like a
Sridhar, you want to say something?
Yeah, so I think like Saurabh already pointed out, it's largely for small tumors. So I was lucky to be part of the erasing trial, which was recently published in Clinical Gastroenterology and Hepatology for insulinomas. So again, there is robust data for insulinomas, not as yet for pancreatic cancer, like already Sir pointed out. But again, in our setting, like Saurabh said, in patients who have small lesions who are otherwise inoperable due to, let's say, comorbidities or otherwise general status, it seems like a good option. Like most of our patients would have gone for irreversible electroporation before to our IR colleagues. But I think, yes, RFA is the better option because it's closer to the lesion. You're doing it under vision. So clearly, it will supersede IRE on that front. And again, with regards to the risk of pancreatitis, there is a recent paper again in GIE which showed that if you're more than 10 millimeters away from the duct, it's a safe window. So anything close, less than 10 millimeters from the pancreatic duct is a risky lesion for development of pancreatitis. So if the duct is more than 10 millimeters away, especially for insulinomas, then it's a good lesion, and maybe the risk of pancreatitis will be less than 1%.
Sir, I would
The
like
first study which was done was a operative study with RF ablation.
Yeah.
They have used 55 patients, and they used a temperature of 110 degrees centigrade, and the complication rate was around 30%, 35%. When the temperature reduced from 110 to 80, the complication reduced by more than 50%. So, as Bhushan has pointed out, high temperature possibly was more deleterious for these patients.
Sir, in cases of sir, excellent management of this patient. Sir, in cases of gastrojejunostomy, wherein we are deploying a self-expanding metal stenting, sir, what would be the life which we can expect of that stent per se?
Normally, we tell to the patient that whatever is the life of the patient would be the life of the stent.
Yeah, I think it's true. I think the problem with the duodenal stems is that tumor ingrowth, and this is the advantage that you're away from the tumor. So that's the advantage in theory for gastrojejunostomy stents. Yeah.
Do you have to do stenting post RFA?
Oh, you mean if I'm pancreatic, right?
Yeah.
I think that's the interesting point, and that's the right thought, because if you're 1 centimeter,
Yes,
you want to put a stent prophylactically,
Yes.
probably, because then you will prevent leak.
Prevent leak.
The leakage is the main issue
Exactly.
with RFA if you're close
Yes.
to the duct. So you put a stent, it'll prevent. There'll be a prophylactic.
So
measure.
prophylactic, yeah. We invite the third speaker, Dr. Saurabh Mukhewar. He will be speaking on large esophageal cancer, patient refuses surgery, what next?
I'll just start my slides for a second. Sorry, we are getting the presentation loaded. Okay, sorry for that. So, okay. Thank you, chairpersons. It's actually very nice to see 4 oncologists sitting and oncosurgeons in the chairing seat here. So this is a patient, large esophageal cancer patient refuses surgery. What next? All right. So this lady, 50-year-old female, presented with progressive dysphagia for almost a year. Interestingly, with mild anorexia, weight loss, and an upper GI endoscopy was performed elsewhere. And these are the pictures, which showed some irregular changes in the mucosa as best as we could see. But the biopsy outside, this was not available for us, showed a moderately differentiated squamous cell cancer. A CT scan was performed. The scan initially was performed about 2 months before seeing us, which was normal, and then we decided to at least repeat it before offering any sort of treatment option. And the CT is essentially normal, and you can see that it's a early esophageal cancer, and therefore nothing is really visible on the scan in terms of a lesion or any enlarged lymph nodes. Additionally, a PET CT was also performed to ensure that everything is fine and there was no metastatic deposit. So therefore, this patient was basically taken for endoscopic submucosal dissection. And what I'll show you is just basically how the tumor looked like. And by the way, this patient had been offered surgery twice and had refused until she came to us. And if you can see, this patient had some biopsies before, so the linings are, the changes are seen from as artifacts from some biopsies before, but you can immediately see that the lining of the esophagus is clearly irregular. There's some nodularity, and there's some neovascularization. So this patient has an early esophageal cancer, and what we are performing in this patient is endoscopic submucosal dissection of this lesion. Now, this lesion was about 10 centimeters in length from the mid to lower esophagus and involving the entire circumference of the esophagus. So how we proceeded is the marking which I showed you in the video. So we start with marking in the proximal end and the distal end of the lesion. You can see the marking was performed, and then we use these simple knives. This is a knife made by Olympus company, and that allows us to perform this dissection. So what we do is a gentle dissection, starting with incision of the mucosal layer, which is being performed. And interestingly now, usually we are used to sort of bigger lumens with smaller lesions, but here we are doing a 360-degree tunneling procedure and dissection. So it has its own challenges as we do this procedure. So this is the incision performed on the lower end that previously was the upper end. I think Previous video, can, right? Sorry. Okay. Can you still see it? I apologize. We are trying to fast forward because otherwise we can't show the whole video for display. Yes. Okay. Okay. Good. Okay. What is that? Okay, there you go. All right, sorry. Okay, so this is how it is. So now we are performing dissection. Now we start from the proximal margin and then we go in a 360-degree manner. And we are doing this in the submucosal space, which is the second layer of the esophagus. Now, in our prior meetings, we've shown you smaller lesions of the esophagus. This is a much larger area. Yeah, sorry, I think there's some AV problems we are encountering. So, I know, but it's not playing. Okay, anyway. Sorry for the delay. Yes. So just to illustrate the point again, this is the dissection being performed. So what you see here on the top layer is the muscle layer, and on the right is the mucosa. And what we're doing is the dissection in the submucosal plane gently in a 360-degree fashion. It does look a little easier than it can be sometimes because of positioning and angles and so forth. So just slowly take it forward. This patient, we ended up having an area where there was an opening in the muscle there, so we had to put a clip. And as we are doing this, we encounter a lot of vessels, which we prophylactically coagulate. And I'll show you something fun. Like we do have some spurting vessels also, like you see there. And then you have to use tools to perform coagulation and effectively treat this. At the end of this, see, last result, right there. Basically, following this, the lesion was removed, and this is much shrunken. This is about 2 times the size actually inside the esophagus. So it's about 11 centimeters in length overall. And what you can see is the clean base, and this is the muscle layer throughout 360 degrees. and there was a clip placed. Now, because of a fairly high chance of stricture formation, we decided to proceed with injection of triamcinolone, which is a steroid, to reduce the inflammation and reduce the rate of stricture formation. And then we also additionally placed a metal stent with the idea that this will expand and prevent a stricture from forming. So the metal stent is now here being deployed across successfully. Okay. This is the gastrograph swallow on the next day, demonstrating absence of any leak. And the histopathology evaluation, and Dr. Ravi can comment on the findings.
Showed moderately differentiated squamous carcinoma, and one could see that the resection margin was absolutely very clear.
Yeah, and this was T1A, right? T1A. Yeah. So this was squamous cell cancer. We got a clear margin, and eventually the fully covered stems was removed. But unfortunately, this patient had recurrence of dysphagia and is undergoing dilation. So this was the case, and I'll just briefly touch upon early esophageal cancer, as a lot of you may not be familiar with this. And then most oncologists, I suppose, see patients in the more advanced stage. So this is something that oftentimes is picked up at an asymptomatic phase or little intermittent dysphagia if they may have. And when we're talking about early cancer, we're talking about carcinoma in situ or T1A lesions, or at the most T1B with a less submucosal invasion. And the reason, and when we offer these patients endoscopic therapy, are largely the ones with carcinoma in situ when the risk of lymph node mets is, say, 0%. With M2, we are looking at 3.3%, M3 up to 10%. And then as we go towards SM1 and deeper, we are looking at a higher risk of lymph node mets, 26.5% or more. And therefore, purely endoscopic therapy may not be of benefit in the patients with deeper invasion. And certainly with the higher and the more deeper invasion, you're looking at more than 50% invasion. So this is primarily the category we would prefer to do endoscopic therapy. And now we do have high definition endoscopes that actually allow us to really look closely at the mucosal vessels and the submucosal vessels. And they form what we call as intraepithelial papillary capillary loops. And these are IPCLs, and based on the appearance of the IPCLs, it gives you an idea as to what is the depth of invasion of this lesion. And I won't go into the depth, but basically you can identify approximately what would be the depth of involvement without taking it out. Now, what is the 5-year survival if you're doing ESDs for these lesions? At high-grade dysplasia patients, we are looking at a 95% survival at 5 years. With SM1, 85%, with SM2 as well, up to 75% survival. So therefore, ESD is a pretty good option for these patients. An alternative which a lot of endoscopists do perform is endoscopic mucosal resection, where you are injecting, lifting the lesion and doing snare removal. And problem with EMR is it's good for small lesions, less than 1.5 centimeter, but the recurrence rate goes up once you have lesions more than 1.5 centimeters. And therefore, it's not really advisable for larger lesions. If you look at EMR versus ESD for superficial esophageal cancer, you see the ESD has a longer duration because it's a more tedious procedure. But when you're looking at an en-bloc resection rates, ESD in this series had 100% resection rates versus EMR, and especially for the larger lesions, when the en-bloc resection rate was down to 64.3%. And as far as R0 resection rate, again, you can see a significant difference between the two arms. So therefore, ESD is preferable and desirable compared to EMR for lesions. And well, I'll skip through some of these slides in the interest of time. So basically, if you're looking at moderate to well-differentiated cancers, you're looking at EMR en bloc for less than 1.5 centimeters. But if it's more than 1.5, or if you're suspecting submucosal invasion, you want to do ESD. It's very important to characterize the margin with high definition endoscopy, and you want to be away from the margin when you're doing this. Overall, but however, ESD has higher bleeding rate and higher perforation rate, if it's not done in experienced hands. So very important that it's done properly. The Japanese are the ones who are pioneers and have led this field. And if what they recommend is endoscopic resection if you're looking at a non-circumferential lesion for epithelium, lamina propria, or muscularis mucosa or superficial submucosa less than 200 micrometers. It's advisable. And for the whole circumferential lesions, they do mention less than 5 centimeters in the longitudinal dimensions. It should be performed. Now, in our case, it was about 11 centimeters, although a lot of Japanese continue to perform it beyond the guidelines, which about 10 centimeters or so. So now the question is, what can happen, what can go wrong? Apart from the intra-procedure issues, these patients can have a higher risk of stricture. And as our patient had stricture, and you can see at pretty much 4 of the 5 risk factors for developing a stricture, which was location in the mid-esophagus, circumferential lesion, I think especially with longer operative time. What can be done to prevent stricture? This is the original study which discusses use of triamcinolone injection, which we did do in our patient, but unfortunately this patient still developed stricture. In this 20 patients without injection versus 21 patients with injection, you can see the stricture rates were much lower, 19% versus no injection group 75%, and the number of dilations was lower in the patients who got steroid injections. What else can be done? You can give oral steroids in combination with this, and then the Japanese have started using polyglycolic acid sheets, which unfortunately are not available for us to use, but something else that can prevent strictures in these patients. So I'll end my talk here. Sorry for those days. Yeah. Okay. I think if you want, I can go ahead with the next presentation as well. Yes.
Saurabh, can I ask you a question?
Yes, sir.
I always wonder, taking out an 11 centimeter circumferential lesion endoscopically, sweating for almost how many hours? 4 hours, 5 hours?
About 2.5 hours.
2.5 hours. And then facing a problem of stricture, putting a metallic stent, self-expandable metallic stents and removing. Do you really feel that it has gained over surgery in these patients in terms of quality of life, in terms of survival, in terms of the long-term outcome in these group of patients, early gastric and early esophageal cancer?
Well, I think as far as the quality of life, let's talk about the first thing in terms of recurrence. And at least as best as I can see, the data is sort of similar between surgery and ESD if we are looking at an early cancer. So I don't think we have lost much on that front. In any case, this patient had been refusing surgery, so this was practically the only thing we could do. So that's first thing. The second issue is a problem of stricture. Now, I agree that I think stricture was a problem, and this patient, unfortunately, we had to manage it, and we are dilating her. But yes, as for this, I think a surgical intervention could be considered, which may probably prevent stricture. Now, she did not have any major comorbidities, but certainly if the patient had major comorbidities, this would have been the only possible option. And I don't think a minimally invasive surgical option would be possible, I suppose. You'd still have to do some degree of thoracotomy, I think.
Yeah, so I feel that we have to individualize the treatment of these kind of things, that patient refusing for surgery, patient having comorbid conditions, are patient really afraid of these kind of major surgeries with post-op complication, we definitely can offer. But the juries are still out, and the time will tell that for these larger circumferential lesions, we maybe sometime in due course of time, it will be decided 3 centimeter, 5 centimeter, 10 centimeter. We'll have to divide maybe different groups, and then we can offer that these are the groups which will be benefited much more significantly by one kind of surgery or procedure than the endoscopic procedure. I'm open to criticism for this comment, but I still am not convinced that we have reached to a stage where we can define or we can identify that, well, this is the one which will require submucosal dissection versus one which will require a surgery. Sridhar, your comment, and Shrikant sir, if you have any comment on that.
Like you said, maybe the length, there is currently, of course, no criterion wherein you can say this is definitely surgical and something is endoscopic. And I think Saurabh demonstrated wonderfully.
Very well, very
Yeah,
well.
I mean, this is, I mean, clearly a masterful ESD. I mean, no denying that. Yeah, I mean, clearly, I don't know where to draw the line between endoscopy and surgery. And I think as endoscopists, as interventional endoscopists, we are slowly trying to evolve into surgeons. Maybe we won't be able to replace them. Of course, that doesn't seem possible, at least at present. But yeah, I don't think I can draw a line anywhere at the moment, at least.
The second problem is we do not have the long term the data on the structure. Okay, this time you have put a stent and triamcinolone. They may have but the long term, because you do not know what kind of fibrosis will happen in circumferentially, even if you have put a stent, because you have to remove this stent 4 to 6 weeks later.
So I often do think that surgery, of course, has its own downsides. I mean, this would have required a pull-up, and this would have required a TTE for all practical purposes. And yeah, I mean, of course, it has its own risks and complications. I'm sure at the hands of an expert surgeon, maybe not so much, but then again, uh, I think at the hands of an expert endoscopist, I think the best outcome was given. So I'm
So here the comparison is between an expert endoscopist versus
yeah,
an
yeah,
expert surgeon.
very much, very much, very much.
And Saurabh, a wonderful demonstration. I must congratulate you for doing an excellent job in circumferential resection.
Thank
Hats
you.
off to you, Saurabh.
Thank you. Thank you.
We'll proceed to the next case, which is again a challenging case of ampullary tumor by Dr. Saurabh Mukhewar.
Okay, I'll make it slightly brief, this one. I know we are running late. So 40-year-old female presented with epigastric pain radiating to back with intermittent non-bilious vomiting. She had peripheral vascular disease, had bilateral iliac angioplasty, history of hypertension, rheumatoid heart disease, diabetes, on statins and aspirin, and an upper GI endoscopy. This is elsewhere, by the way. I think had shown a of irregular mucosa with biopsy showing low-grade dysplasia. And the patient, well, I'll show you. This patient had a flat lesion actually involving the ampulla. And this is what the lesion was. Again, almost 75% of the circumference in the duodenum involving the ampulla. It was a LST lesion. I did not do a ESD in this case. Maybe in future, I don't know. But what we are looking at is about, say, 3 centimeters at least, or 4 centimeters in length, involving about 75% of the circumference of the duodenum as well as the ampulla. So these can be slightly tricky and challenging to manage, as duodenum is a very vascular area, and removing such lesions can be a little challenging. So what I'm going to do is just escape for a second, and going to switch back to this view, because otherwise I'll have to play the whole thing. Right. We did a EUS, and well, not of much benefit because of early lesions. You don't really see much in terms of depth of invasion or so. We start typically when we are dealing with anything with the ampulla. We prefer to actually, I actually like to do a quick ERCP first, gain access to both the ducts, the bile duct as well as the pancreatic duct. In this case, I ended up doing a little sphincterotomy, which don't always do. But basically, to ensure that we gain access back into the pancreatic duct, because there's a higher risk of pancreatitis if we don't put stents. So that's why I did decide to do a sphincterotomy, just in case I don't get access later, I have issues. And what I decided to do was a serial EMR. This is the as I showed you in the previous presentation, another technique of removal of superficial lesions. So what we are doing here is endoscopic mucosal resection. It's a serial piecemeal EMR. And what we basically do is perform an injection of methylene blue normal saline at the base of the lesion and lift the submucosa. And then with the snare, we go one by one piecemeal and we go ahead and take out the tissue. So here, one by one, we are removing the pieces. And as you see, all these pieces inside the duodenum again removed, and I'll just keep going here. So the key is for those who are planning to start it or have not done much of it, we do decide to take some smaller snares because you take a bigger snare, there's a higher risk of complications. So our preference is smaller snares and go piecemeal one by one. As we inch towards the lateral part, these are some of the very relatively tougher areas, the duodenum. Moved all these pieces, and now we are looking at the base, and there's oozing as expected because duodenum is very vascular. And what we did is use the tip of the snare, and then we use that to perform coagulation of the vessels at the base. So here you can see some small oozing vessels. And then we use the snare tip to perform cautery. Now this is a large defect, so I did not even choose to perform clips. Ideally, yes, putting clips would be beneficial to prevent bleeding, but this was a large defect, so we just chose our endoscopic tools. We're using this coag grasper. This is something we use in ESD and POEM. And additionally, what I did was I got as best as I could, I ablated the margins of the EMR with argon plasma coagulation. The idea is that this should reduce the recurrence of any dysplastic areas. This is how this was performed. The entire lesion seemed to be out, and then we gained access back into the ducts. We put a stent in the pancreatic duct, and then one in the bile duct. The entire lesion was removed. Yes, this is for them. Yeah, actually, this was a CT scan done before. Anyway, so here's the histopathology, and Dr. Ravi, if you, so this patient actually had high-grade dysplasia and intramucosal carcinoma, but the margins were clear despite the piecemeal part, whatever was removed seemed to be clear. And so the reason I'm also showing this case is because of the challenges that we encountered. So now this is the patient, we bring the patient back on follow-up, and so we brought the patient back on follow-up, and you see the whitish spots, and unfortunately there is a residual lesion and just at the proximal margin of the ampulla, and then one was along the lateral part. So so we went ahead, injected and lifted and removed this portion. And this was a little hard because all that area gets scarred down. Removing can be a little bit of a challenge. So I used biopsies in addition, and we took it out. And then problem was this lateral one, as I attempted injections, and despite injections, we could not adequately get a lift of that lesion. So what we decided to do in such a situation is, so now when you have a small bowel lesion which is scarred and you can't remove it, so thankfully we now have some better tool here, and what we have here is the over-the-scope clip. So this is a clip we've shown in the earlier presentations for bleeding in the past, and here we are using it for putting it at the base of this residual lesion which was scarred, and then I'm using a snare to cut this residual lesion out. Otherwise, there's no other way really except for ESD, I suppose, for doing removal of this lesion. So this was eventually removed, and finally, patient is fine, asymptomatic. Follow-up, I don't have the video, but the patient is doing fine with no residual disease anymore after a year and a half. So this was something that was challenging for us because you can do it, as the primary case was slightly difficult as is, And then the recurrence of lesions can be a bit of a nuisance. So this tool is very helpful, and we could eventually get the whole lesion out. So I think for laterally spreading tumors, there is some degree of apprehension whether this should be dealt with in a surgical fashion or endoscopy is okay. And this is one of the earlier studies looking at 10 patients from Michael Bork from Australia, who's a pioneer in EMR, and 10 patients undergoing EMR of LST. This is LST stands for laterally spreading tumor of the papillary adenoma. They had a 10% recurrence rate, about 30% bleeding rate, and then there are some recent studies, and you're looking at long-term outcomes of this particular series. 161 patients, out of which 35 had laterally spreading tumors, which tend to be larger with requiring more piecemeal resections. But there was no difference in the recurrence rates on the long term between the two. And then another study here looking at 20 laterally spreading tumors out of 87, which tend to be a little larger in size. And curative endoscopic resection was not different between the two arms. And there was no difference in complications or recurrence rates versus standard ampulectomies. So I'll end my presentation here, and I'm happy to take any questions for this second case. Thank you.
Excellent. Saurabh, what was the final histopathology of that particular?
Oh, just adenoma. The residual areas?
Yeah.
Adenomatous tissue, yeah. It was not cancer. That was adenomatous. Yeah, no, I think a good point. I think with the band EMR, I'm not sure if the scarred lesion, it was not lifting, so I had my concerns. But you're right, I think that could have been the other alternative. Something we could have tried at least, yeah.
A theoretical question. Based on your review of literature of these kind of, how many of these patients end up with some degree of pancreatitis, mild or moderate pancreatitis?
I wouldn't say I've done hundreds of these, but although 15, 20 ampulectomies that I must have done so far, fortunately, I've had barely any pancreatitis because we've been successful in putting a pancreatic duct stent in all of them. So I think the issue is when you don't get the PD stent, it's then when the edema starts and the healing occurs and the papilla gets blocked, they develop pancreatitis. But I suppose if you have a PD stent, it should be okay.
So do you do some pancreatic sphincterotomy before starting your EMR in
No.
these patients?
Actually, usually I don't. I do a PD cannulation, I get a pancreatogram, I leave it alone. This case, for some reason, I thought in case I don't see the PD axis, and let's just do a little cut, but we'll make sure we get it out. So we can, I guess, think either way. Maybe, I don't know if that led to recurrence at the site proximally, but yes. Sridhar, happy to have your comments as well. Yeah.
Last
sir.
question
Sorry, yeah.
before Sridhar takes up. So do you inject some methylene blue along with dye in the pancreatic duct for the better identification, and simple dyes, that's all which you inject?
You mean after or before?
No, before starting the procedure for identification of pancreatic duct.
Oh, I've not.
Post EMRs.
Yeah. I think if you see it, I have not quite done it before. I don't know if anybody else has an idea, or Sridhar, if done it, not.
So at
Just
least
a
I never used
theoretical,
dye.
theoretical question.
Mhm.
Yeah, I've never used a dye before. Even I never do a sphincterotomy. I guess
Yeah.
clearly I think Saurabh wanted a safety margin here, so maybe
Just
yeah,
a shot.
maybe I would have also done it given the size of the lesion. Yeah, but otherwise, even for an ampulectomy, I never do a
Yeah. Fair
sphincterotomy.
enough.
Direct resect, and usually you're able to find the PD orifice. I've never had a situation, touch wood, I've never had a situation where
And in
there are no.
ampullary adenoma, when you do ampulectomy, you elevate it again with the same methylene blue. And,
No elevation,
no.
no elevation.
No elevation.
No elevation.
Only for LSTs you'll have to.
Yeah, only for LSTs.
Yeah.
Okay.
which
you see on defer an endoscopic ampulectomy.
So I think intraductal extension and to the extent and degree, number one. And second is if there is a deeper invasion into the muscle layer. If you see, you're not confident it's cancer or not. Cancers, basically, you should not be touching by and large. But if you're not sure and then you do EUS and you see it's hypoechoic, going deeper, then again, you should not be doing it. Intraductal extension, little bit, you can tackle with snares and maybe RFA distally. But if it's more proximal or anything, then you have to think twice.
Any cutoff like
Yeah.
3 4 5 like that?
Of the
Intraductal extension.
I don't think, because they're often like polypoid, you can snare and take it out by and large. I've not seen anything more than half a centimeter ever.
The
Personally,
guideline would say 20 millimeters. ESG guideline would say 20 millimeters, but yeah. But then again, I don't think any of us are doing 20 millimeters. So yeah, maybe 5, 7. Yeah, maybe yes.
Saurabh, did you do frozen on that?
No, this was a complete histopathology was sent
Later
across. Yes. Because we do not. I did not
You're
feel
not
any
sure about
cancerous
it,
changes.
yeah. If
There
you're
was
not
low
sure.
grade, high grade dysplasia. It seemed more adenomatous. It did not seem to have underlying malignancy on the look of it.
Okay.
But yes.
Saurabh, I have a couple of questions on the first case. In fact,
Yes,
this
yes,
was
yes.
not discussed. So I've done a couple of these long circumferential ESDs. I saw your technique. You didn't put multiple tunnels, but you kept on circumferentially doing it and pushing it down. So what is the advantage versus at least 2 or 3 tunnels and you join the tunnels laterally? That's number one.
Yeah.
Number two, I also had this problem in spite of putting triamcinolone and metal stent, which I didn't do on the first instance. I did after 6 weeks or so because the stricture developed. Even that metal stent failed, and again, dilatation is what actually worked. And
Yeah.
I think there's more now thought that dilatation can be a good option. You are already asking the patient to spend so much on ESD first and then putting a fully covered metal stent, a big expenditure.
No, good point. So I think the first question was the technique. So I've done a few of these. Some I've done circumferentially, others tunneling and joining. So I think sometimes it's easier to do a 360-degree movement. Therefore, it's fine. The challenge is when you go 5 centimeters down, then I think there's some areas which is cut less and more, and then going lateral can be a problem. Tunneling and laterally going, again, I find the lateral part to be a bit of a challenge. So as much as possible, I do 360-degree and going equally at a pace down as I go through the tunnel.
IT knives work
Better
when you are
lateral. Yeah, I think I'll use IT knives at the end when there's some tethered and last little bit remaining. So yes, I've done it both ways, and I've done the tunnels 1, 2, and then joining them as well. You can go either way, whatever makes you comfortable. The other second question is stent stricture dilations. Yes, I think savory dilations work better. Ultimately, I think we offered the best we could for the patient so that to reduce the risk of stricture, because I knew it's 100% happening. Stricture is coming, so there's no way around it. So we decided to at least give it the best shot to prevent it from occurring. That's what.
Yeah, then again, you had the perf also, right? I mean, you put a clip, but then again, you had the perf. So clearly, I think you had to put the stent.
That was already there. So
Yeah.
both ways it worked.
current status of this drug-eluting stents like steroid-eluting and stents with acellular matrix, something like described in the literature. So is it available or it's just on the studies?
No,
only?
I've not personally come across. Anybody else has? I don't know.
No.
Okay.
The question is about drug-eluting stents.
No. Not routinely available.
Yeah.
Thank you, Saurabh. Wonderful presentation.
Sorry. Thank you.
So, I'd like to call upon Dr. Akshay Kulkarni, who will be presenting a case of new approach for treatment of duodenal anites. So, please be brief so that we can have more time on discussion.
Good evening. Am I audible? Okay. So the method that I'm going to describe is short and sweet. Doesn't take 2.5 hours, and yeah, but it's kind of risky to the eye of an inexperienced endoscopist like myself. Yeah, so I'm describing my first case. This is a 45-year-old female with no comorbidities. She was otherwise fit. She came to us with right upper quadrant and flank pain for 1 year. She needed painkillers for this symptoms frequently, and this was worse after food. The endoscopy was done for the usual indication of dyspepsia. She also had loose stools on and off. The endoscopy showed 1 centimeter D1 lesion, and the biopsy from this lesion, the mucosal biopsy from this lesion showed a neuroendocrine tumor. So we decided to take it out endoscopically. So this is the EUS showing this a small lesion in the second layer. It was not infiltrating any of the lower layers or not crossing the submucosa or the muscularis, as you can see. So this is a short 1 by 1 centimeter lesion. We went ahead with the so there are two lesions actually, one smaller lesion on the opposite wall, and the posterior wall of D1 showed a larger lesion, which is the one we are targeting. APC was used to mark the outlines of this one, and this is the full thickness resection device, this so-called FTRD. So what we did was we deployed the FTRD across the margins of the lesion. We carefully marked these margins and then sucked the entire lesion inside the device. The device simultaneously applies a clip on the other side of the lesion after suctioning the whole lesion inside, and prevents a transmural perforation. This way, one can see that the layers of is my cursor visible? No. So the uppermost layer over here is the resected mucosa and submucosa, and the lowermost white layer that you can see is actually the muscle. Dr. Ravi sir just informed me that he had to leave. So the biopsy of this lesion showed clear margins with an R0 resection. This was a grade 1 well differentiated neuroendocrine tumor. Patient was completely cured and on follow-up was asymptomatic. And a smaller lesion we removed with ESD. So the histopathology was clear and the patient remained asymptomatic later. In the second case, now we have a more complicated case for endoscopic interventions. A 64-year-old male with multiple comorbidities and on psychiatric medications as well. Recurrent abdominal pain and loose stools again. A large D1 lesion this time. Another well-differentiated neuroendocrine tumor on biopsy. And this is the EUS again showing absence of infiltration in the deeper layers. A smaller lesion this time, 9 by 7 millimeters. And this also was taken into the device after carefully marking around the lesion. This was on the medial wall of the duodenum, so it was easily approachable and visible compared to the one on the posterior wall. So markings were easier, and the lesion came onto the on-fast view in the upper GI scope, and we deployed the device, and after applying suction, one can pull the lesion inside the scope or inside the device before applying the clip. The clip as well as the retracting device comes as a combination. A slight bleed, but ultimately we were successfully able to deploy the device. And this is the resected lesion. The base of the lesion with the clip is visible. It was clean. There was slight self-limited bleeding, but no complications otherwise. This is a schematic showing the FTRD device. The first diagram shows a submucosal lesion being targeted with the device. One has to make sure that the lesion is small enough. Generally, lesions up to 2 to 2.5 centimeters can be targeted with this device, and one can suck the entire mucosa and submucosa, the lesion above, into the device and apply a clip simultaneously, thus completely resecting it. Also, it takes the serosa as well in the clip, so it prevents a perforation. So indication uh, of this device has been extended to superficial adenocarcinomas and duodenal adenomas. And many lesions have been successfully resected, most of them in the descending part of the duodenum, which are in direct view of the upper GI endoscope or the therapeutic gastroscope, with a technical success of around 85%. And the target lesion can be accessed with FTRD up to the duodenum in 95% of the cases. And a complete resection, even microscopically, an R0 resection can be easily achieved in almost 2/3 of cases over here. So yeah, on follow-up endoscopy, very few tumors recurred because some of them might not have been R0 microscopically. So very few recurred, but we did have yeah. Yeah. So this is another paper where Dr. Saurabh sir is also one of the authors, where an international collaboration between multiple endoscopy centers reviewed a data of 56 small lesions subjected to FTRD. So out of those 56, many of them were in the duodenum, but one was in the esophagus as well, which is unusual. Submucosal lesions predominated the entire list, and technical success was obtained in almost more than 2/3 of cases, with more than 2/3 of cases also showing histologically complete resection. So an R0 can be achieved easily up to 70%. And another so if you're targeting a smaller lesion with the objective of an R0 resection, then FTRD can be the way to go. Thank you very much.
Excellent presentation. How sure you are when you are applying that gadget, that you are not pulling the serosa with it?
So as I show, as the schematic in the figure shows, as far as I understand,
Is there any mechanism, because we are not aware of it?
Yeah. So when the lesion gets pulled, if the lesion is small enough for the grasping device to pull it, maybe even the deeper layers such as muscularis propria and even the serosa can get pulled. But the clip gets deployed all the way around the lesion. So any kind of defect gets successfully closed.
In cases of inadvertent perforation can happen in such cases?
Yes. Perforations have been recorded, especially in the larger series of multi-center study that I just showed. Perforations have been present, definitely, but none of them requiring any additional intervention or especially surgical intervention.
So those clips which have been applied, they should be fine enough in cases of perforation?
Yeah. So most of the times what happens is, I can imagine that the larger lesions which were tried for being targeted, or maybe the lesion which did not completely fit, or maybe the scope orientation was not in an exact angle where the complete lesion could be sucked into the device, then one can have a partial closure of the defect, one can have incomplete resection, and one can leave a defect in the serosa as well from some of the angles, and that can lead to a complication.
So do you do some test there, inject something and see that where there is a small perforation or there, or no, you just come out?
So of the two cases that we have done, I'm not sure.
No, so I can
No, in
chip
doubt.
in, yeah.
When in doubt, can you inject something and see? Or
No, so basically, see, I think the idea is, if you think endoscopically, we usually limit ourselves to mucosa.
Correct.
Right? And when it goes deeper in muscularis propria, we are not touching those lesions typically, because it can lead to perforation. The idea of this device is that you can actually close the future perforation. So what has happened is you've pulled the lesion inside, you have put a clip to close the perforation that will happen after you cut it. So it's a very ingenious device that your future perforation is already closed and the clip is deployed on top. So therefore, perforations technically shouldn't happen. Now, I have not experienced it. I don't know, Sridhar, have you seen or experienced it? But I have seen one video when they showed us during the training of this device initially, where somebody was being a little misadventurous and, maybe the sheer pressures of the lateral wall led to perforation or something, but that should not typically happen. I think one thing we should be careful about are any underlying vessels. So I like to do US partly to look and see there's the big GDA is not going below the vessel. So then when I'm deploying, just in case there's a risk that I touch the GDA along with that, should not happen. So that's something we take care of. Apart from any extra luminal involvement. So Dr. Jain, Sridhar, any comments, I guess? Yeah.
So the issues with the device are that the device is big. So yeah, I mean, if you have a short patient, negotiating it across the cricopharynx and even across the pylorus is often difficult. But otherwise, if you're actually negotiating it well, uh, there are clear markings to the lesion. So you're able to grasp the lesion because of the markings. You're able to see the markings while deploying the clip. So there's a clear indication of how the clip is being deployed. And again, there is a safety on the clip itself. There is a white rim that you can see moving to make sure that the clip is actually deployed. Like you're saying, of course, mishaps can happen. It's a device. Failures are known to happen with devices. But then again, there are safeties given on the device itself to ensure that it is deployed appropriately. I've had a situation where sometimes after deploying the clip, you often lose the grasper. In this case, what happened? You're holding the lesion, the snare closes, and you're cutting in the same setting. But sometimes what will happen is you deployed the clip, but you lose the grasp on the lesion, and the snare doesn't cut. So then you have to pull the whole thing back again, go in with an upper GI again with a snare and cut the whole thing. Yeah, that can happen. But yeah, overall the device is an excellent thing, especially for deeper lesions. NETs, great lesion, especially in rectal nets. It's an excellent device to have. Rectum, colon, scarred lesions, very good device to use.
Okay.
Excellent presentation. My only worry is that I hope there are not much surgeons in the audience. Otherwise, Saurabh, they will give supadi for you.
Thank you so much. So we would be proceeding for our last case, that is large colon polyp in a high surgical risk patient. What to do? By Dr. Atif Patel.
Good evening, everyone. I guess we have this enigmatic lesion standing between you guys and the dinner. I'll try to finish up the talk fast. So the first patient, known case of type 2 diabetes, hypertension, coronary artery disease, past history of CABG along with mitral valve replacement done just 1 month back, currently on dual antiplatelets. She presented to us with PR bleed since 1 week. It was mixed with stools. So we went ahead with a colonoscopy, and you can see in the cecum there is presence of melanic stools. Along with that, there is a large lesion, a large polyp located. So we went ahead with the biopsy of the lesion. Before we get the biopsy, we did a CT scan, which is suggestive of a large colonic polyp, long pedicle attached to the medial wall of the cecum. However, there was no infiltration of the colonic wall. The biopsy came out. The biopsy, as you can see, it's a hyperplastic polyp. Deeper magnification, you can see there is an atypical mucosa, hyperchromatic nuclei, and there is a foci of focal signet ring cells along with intramucosal adenocarcinoma. So what would be the further plan of action? Should we go ahead with surgery? As we know, the patient is having multiple comorbidities, as well as the relatives were reluctant for surgery. Should we go ahead with chemotherapy, particularly the today's newer treatment regimes, the panitumumab, the dostarlimab, and other immunotherapies, or a simple 5-FU regime. But if we go for chemo, the potential for achieving a full cure would be compromised. So we should plan something in between, and therefore some minimally invasive approach should be planned for. And therefore we went ahead with an endoscopic submucosal dissection. So first we localize the lesion. The lesion is in the cecum. In an NBI mode, we can see the type of the lesion. We delineate the lesion. After delineating the lesion with a coagulation, first we start with injection of a fluid. As sir had said, we inject methylene blue along with either normal saline. Once we inject it, once we inject the fluid, we start cutting the mucosa first. The mucosa is incised. Once the mucosa is incised circumferentially, then we start dissecting the lesion submucosally. Multiple knives are available for dissecting the lesion. If we see any bleeding vessel, as you can see here, we use a coag grasper to grasp and coagulate the bleeding vessel. So the type of multiple needle knives are used. So we have the TT knife, we have the IT knife, the dual knife, and the hybrid knife. The IT knife is the one which has a ceramic base, which we'll be seeing. Fast forwarded. So as you can see, we start dissecting the submucosa. Once the complete submucosa is dissected, we can then remove the lesion. This was the ceramic IT knife which I was talking about. Then we remove the lesion. Once we remove the lesion, you can see complete en bloc resection of the lesion was obtained. This was a 3 centimeter lesion. Once you have removed the lesion, you keep it on a table, and proper orientation is very much necessary for the pathologist. We orient one luminal side on one hand and the submucosal or muscularis side on the other hand. The reason for proper orientation is for the pathologist to make a proper 2 millimeter dissection and find out whether any submucosa was involved or not. In our patient, the post-procedure was uneventful. He started tolerating oral feeds the second day and was discharged in stable condition. The biopsy again shows intramucosal adenocarcinoma of the resected specimen. Our second patient, similarly known type 2 diabetes, hypertensive, history of spinal artery thrombosis secondary to cost ischemia leading to severe back pain and paraplegia in December 2022. Currently on antiplatelets, he presented to us with bleeding PR since 2 weeks. We did a colonoscopy. We can see a large polyp arising from the hepatic flexure. We took a biopsy. The CT scan is also suggestive of the same. The biopsy, as you can see, it's a classical adenoma. You can see hyperchromatic nuclei and stratification, so probably a low-grade dysplasia. What is the further management? Again, should we go ahead with surgery or a minimally invasive approach? So we planned for an ESD. Again, after demarcating the lesion, we start injecting methylene blue with gelofuscin in this case. After that, so that the submucosa is separated from the muscularis. After that, we make the incision. The mucosal incision has been made. After making the mucosal incision, we started dissecting the submucosa with our dual knife. Now, although it can be seen a much easier approach here, but it was very difficult for us because the lesion was located in the hepatic flexure. So again and again, the scope was falling down and it was difficult to obtain that position. Many a times in such cases, we can do a pocket ESD where we can use and just make an upper incision so that the scope does not fall back. Second, gravity also plays a role. Gravity makes it difficult for the lesion because the mucosal flap falls on the scope. Tunneling, as sir had described, is used only in esophageal ESD. So now, after the incision, we are dissecting the submucosa. I'll just fast forward it. Any bleeding, the bleeding can be stopped with a coag grasper. Now, because it was a very tedious, a lengthy, and a very difficult procedure, So then we planned for using a snare and partly removing the lesion. Now, ESD is a procedure which requires considerable technical skills. It has a long learning curve. Particularly while doing a colonoscopy, it becomes a more difficult procedure because of the flexibility of the scope and of the colon and the scope falling down. So, although we successfully snared the lesion and we removed it, but it was just partially done. So, part of the lesion was still there. Whatever lesion, we removed it with the basket, and then we did the same process again the second day. So, on the second day, again snaring was done, and we tried to remove the lesion. And here you can see a bleeding spurter. Again, this bleeding spurter can be managed with a coagrasper forceps. Coagrasper forceps successfully coagulating it, but because the bleeding was so torrential, we also had to think of a second endotherapy. So in such case, a clip can be applied, and that is what we did next. Hemostasis was successfully achieved. So basically, the two techniques for removal of pre-malignant and early malignant conditions include EMR and ESD. EMR, you simply inject the fluid and then you snare the polyp. Submucosal lesions would not be achieved with EMR, number one. And number two is en bloc resection is difficult if the lesions are quite large. So an ESD is just first you the coagulation and mark around the tumor, then you inject the fluid, a methylene blue, and after that you make an mucosal incision. After the incision, you make a submucosal dissection and you dissect out the tumor. So again, EMR is not successful for larger lesions. For larger lesions, ESD is something which is preferable. And secondly, en bloc resection can be achieved only with an ESD. So exact histopathological evaluation, whether submucosine involved or not, that can be done with ESD techniques. Multiple indications. This is, as sir had before only told, a laterally spreading tumor. On NBI, particularly the non-granular type, have more chances of submucosal invasions. One of the indication of colonoscopic ESD. Second, you use an NBI and see the pit pattern. So the polyps either would have a round, asteroid, tubular, etc. If the pit pattern is irregular or absence of pit, this is type 5. So this indicates that probably a submucosa would be involved. So another indication of ESD. Shallow submucosal invasion, a large depressed type of tumors, large protruded type lesions as in our two cases, or in a baseline of chronic inflammation if there is presence of DALM. Dysplasia associated lesion or mass. Although this term is no longer used, but anything similar to that, an adenoma or any lesion protruded, ESD would be preferable in such cases. The problem with ESD is that it's a very technically difficult procedure. Endoscopic maneuverability is poor because of colonic flexure and extensibility, and the learning curve is long. It requires pretty good expertise. The chances of bleeding and perforation are also pretty high. So these are the studies. And as you can see, although in all these case series, the en bloc resection rate is pretty high, however, the complication rate ranged from 10% to 17%. This is the ESG guidelines. I will not go into detail of the guidelines, but all I can say that if you have an intramucosal adenocarcinoma, no submucosal invasion, or the submucosal invasion is SM1, that is 1/3 of the submucosa or 1000 microns, then no follow-up is required. Just after ESD, nothing further is required. However, if it is SM2 or SM3, then we should consider either surveillance or a chemotherapy. Thank you.
Thank you, Dr. Atif. Very challenging cases managed successfully. So, any concluding comments from you, sir? Yes.
Yeah, please go ahead. Sridhar, you're mute.
So both excellent cases. Clearly, large colonic polyps and minimally invasive approach via ESD is pretty much the way to go, especially in the colon. It's a good organ where you can actually do ESD. Rather, it's usually rectum is the place where most people will learn doing their endoscopic submucosal dissection. So clearly, but again, colon, especially the right colon, that was a difficult lesion. So yeah, excellent cases, both of them, and of course, very well handled, and clearly avoided major resection by doing ESG. So yeah, great cases, I should say.
I only want to thank the online chairpersons as well as the chairpersons here for this being extended program. You know, it's already 11:30, and I can see Ajay. You work throughout the day, and you're feeling so sleepy, but you're still on. So I must give credit to you.
Yeah, I'm little occupied these days with my preparation for Endocon.
Right.
So I request all the people there, especially all my oncophysician friends and oncosurgeon friends who are there in the conference at MIDAS, to join me at Indore on 7th, 8th, and 9th July to see similar cases live, where the endoscopists are slowly and slowly getting into the shoes of surgeons and making the life much easier and comfortable for the patients. So once again, congratulations to all the presenters, and request all of them to be at Indore from 7th to 9th July for Indocon 2023.
Thank you. Sir, one quick question. In cases of multiple colonic polyps, what would be the threshold for us to kind of consider these modalities like EMR or ESD in cases wherein we find a surprising diagnosis?
Bhushan has removed 30 to 40 polyps from one person from Chandrapur. So it all depends upon how the polyps are. I mean, if they are having long stalk and you can remove and the intervening mucosa is normal. But if the patient has familial polyposis coli, FAP, familial adenomatous polyposis, where there is a malignant potential, I think the total colectomy is
Colectomy should be
a
done.
treatment of choice.
Surgery should be.
Yes, nicely we concluded our MIDAS CME on oncology, especially a part one. I really thanks my chairperson, Dr. Anand Pathak sir, Dr. Ajay Mehta sir, Dr. Amol Dongre sir, Dr. Abhinav Deshpande sir for chairing the session, and also online chairperson, Dr. Ajay Jain sir, and also our dear Dr. Sridhar Sundaram sir for chairing online this thing. So we also thanks for about sponsors for organizing this CME, and really welcome all offline persons to join up for cocktails and dinner, sir. Thank you all. Yes.
Thank you. Thank
Good
you.
night, sir. Good night, online
All the
chairpersons.
best. All the best. Bye
Yes.
bye.